Good morning, afternoon, or evening, wherever you all are joining us today, and welcome to our International Menopause Society webinar. It is an honor to moderate the lecture this morning on a very important topic that is often part of our everyday conversation in the clinical setting with menopausal patients. I'm Professor Jennifer Allen, an OBGYN in Augusta, Georgia, and privileged to be here with you all today. I would like to introduce you to our speaker, Professor Mark Brincat. He is going to talk to us today on skin and connective tissue aging at the time of menopause. Professor Brincat is currently professor at the University of Malta Medical School and clinical professor at Queen Mary University, London. He is also an associate dean at Bart's Medical School and served as chairman and director of obstetrics and gynecology with the Department of Health on the Maltese Islands from 1991 to 2018. His academic work has focused on gynecological endocrinology with a special interest in menopause, and his PhD at King's College concerned work on the relationship of the menopause and HRT on connective tissue, particularly on the skin and bone. He founded the first Maltese assisted reproductive technology unit and has also had a long-standing interest in reproductive endocrinology and infertility. Professor Brincat continues to lecture both undergraduates and postgraduates and is still actively involved in menopause and infertility, recently developing an interest in the application of gynecologic laser techniques. So we're going to have about 40 minutes for the lecture, and we'll reserve time for your questions at the end. Please type your questions into the chat, and we will have Dr. Brincat address them following the lecture. I'll now give Professor Brincat the floor. Thank you all for being here.
Thank you very much, Dr. Allen. And I know that you're from Augusta, Georgia, actually, and I've got some links with that. But of course, Professor Greenblatt, who was the father of menopause studies, came from Augusta, Georgia. And I actually had the pleasure of knowing him personally in London. He wanted me to go and work with him for a while, but I suppose I was too British to do that at the time. I hadn't finished completely. But I had introduced him to the one thing I introduced him. I mean, he introduced me to a vast amount of things, especially to my boss, John Studd. But the one thing he didn't, I didn't manage to show him was the first micronized progesterone in the 1980s. He could not believe that there was an oral preparation of progesterone. And I happened to have some in my pocket, and I showed it to him while I was giving him a lift. But he was a wonderful man, But more about him at some other stage. So that's very nice of you to be there. And give him my greetings, wherever he is. So I'm going to start my lecture. It's been extended a bit to include collagen changes with age. And we are talking here about aging skin. We are coming away from the concept that your skin is what you are medically like, to your skin is actually a cause of disease. As we age, there are changes that occur in the epidermis and in the dermis of the skin. The epidermis is, you remember, stratified epithelium with a stratum corneum at the top, and you've got these dermal papillae that anchor the skin, the top of the skin, the epithelium, to the dermis. The dermis has got a lot of collagen in it, a lot of glycosaminoglycans. It's essentially a collagen, mostly type 1 and type 3 collagen, and it's got these hydrophilic molecules, including glycosaminoglycans and hyaluronic acid. It's very similar to any other connective tissue, and it does have a number of capillaries and blood vessels. So hormones that influence it tend to be androgenetic, and hormones that do not influence it, or withdrawal of hormones, will cause lack of blood vessels with its concomitant change to your collagen. But with age, you do get inflammations. The skin is the largest organ in the body. It's a barrier. It's a barrier that keeps us intact, because we are essentially water animals who evolved to the land environment. And if you get repeated abrasions, repeated effects of aging, you get also chronic inflammation. And chronic inflammation is one of the hallmarks of the menopause, actually. And this chronic inflammation does not come without a price. If your autoimmune system is off sync, you will get your cytokines and other inflammatory markers, which will be present in the whole body. They're triggered off in the skin, but they're then found causing problems with your brain, leading to an increase in Alzheimer's. So the poorer, your weaker your skin is, the more likely you are to have Alzheimer's, the more likely you are to have osteoporosis, the more likely to have essential hypertension. So everything is a sort of chain, but we can't say that the effects of the skin are due to metabolic disease only. The skin in its own right can cause disease. The rest of the organs, several of the organs are associated with aging. And there's a lot of work done on aging right now. It's a big study that's just been concluded. That there are about 4 drugs that can actually influence aging. Interestingly enough, one of them is Viagra, sildenafil citrate. Another one is metformin, and you've got estrogens, but estrogens and sildenafil citrate come up tops with statins, which are always also anti-inflammatory, apart from being anti-cholesterols, also affecting general health and slowing down aging as a whole. But that's not the subject today, but just to tell you that skin is not just skin. So if I can manage to do this, some of our earlier work here showed that, and this was John Studd and myself. I'm trying to get rid of this box here. Good. Some of our earlier work showed that if you gave somebody HRT, hormone replacement therapy, at any time after the menopause, you could get an increase in skin collagen. And you can see here patients who've been untreated, and you can see this big drop in collagen here in the dermis in the first. This is biochemical markers for collagen, directly measured from skin biopsies. We can see this quick drop, which reminds you in the drop that you get with osteoporosis. And here you get this quick drop that then levels off. But in treated women who are treated for 2 to 10 years, these are treated with hormone implants introduced to us by Professor Greenblatt. And then they were for a while produced on the franchise by Organon. And then suddenly they're not available in Europe anymore, and we're back to getting them from the States. They're quite popular in Britain and former colonies and in Scandinavia. But anyway, just 2 years worth of HRT would bring you back to your premenopausal levels of collagen, such that these women here, who are 15 years postmenopausal, were given HRT for a mean of 2 years, and their levels are at premenopausal levels. So we suspected then it was possible to increase your connective tissue and to rejuvenate it, if you like. I don't like the word, but that's very popular. Even if you had already lost substantial amounts of collagen. And here's a prospective study, unlike the cross-sectional study before, where women were given, postmenopausal women were given an implant here of 50 milligrams of estradiol, 17 beta estradiol. And this was repeated, as was the time here after 6 months, and looking at skin thickness itself measured radiologically, just the skin thickness of the dermis only, not using calipers, which picks up fat. Then you can see that the amount of skin thickness leveled out. So you did not keep on increasing your skin thickness ad infinitum. But these were highly statistically significant changes from baseline, and they were happening not simply because your collagen was increasing, but also because your hydrophilic molecules were increasing. And your hydrophilic molecules are responsible for skin dryness. I mean, these molecules can lock in as much as 90% of their weight in water. So they will increase elasticity of the skin, will increase hydration of the skin, and have an anti-wrinkling effect. And here is another study by Freshimont, and they were looking at vertical elasticity, i.e. the instance of wrinkles, the effect of hormone replacement therapy on postmenopausal women. And the women in blue here, this is a very funny slide, but it's his work, so I just produced it verbatim. The blue dots, if I can find my mouse, the blue dots here represent women on HRT, the red dots represent women who are not on HRT, and basically elasticity increases if you are on HRT. Now, elasticity contributes to a lack of wrinkling. Of course, now wrinkling is caused by the things like solar degeneration, for example, from being sunburnt, from bathing for too long. But if in non-sun exposed areas, elasticity is also lost with loss of HRT, with loss of hormones, with your menopause. And it is the loss of elasticity that gives you wrinkles. So wrinkled skin is non-elastic. It's the same as with prolapses, for example. Prolapses have lost their elasticity. They're not springing back into position. Your pelvic floor is not springing back into position. It's falling. So it's the same story that's repeating itself. And the skin changes are improved with postmenopausal estrogen use, which is independent of age. So the menopause is the final arbiter here, and this has been shown repeatedly by other authors such as Gambacciani and Castello-Branco. And really, the menopause is the important variable. Once you introduce estrogens, we can replace skin thickness or skin collagen and even epidermal hydration and the layers of stratified squamous epithelium. So here showed that you can increase the postmenopausal epidermis from a mean of 3 cell layers to about 5 cell layers, and improve also the dermal papillae, which anchor the skin, making it less likely to tear and cause this sort of the age-related fatigue that one gets. Another work by Pierre Strachebon looked at the skin water holding capacity. There had been previous works on rats which showed that a castrated rat can increase its water holding capacity in its skin by 90% just 2 weeks after starting on HRT. So these are incredible amounts, and very quick reversal of water holding capacity in castrated rats, who had lost a lot of their water content and then been put on estrogens and replaced. And this was replaced very quickly. Moving on, lots of other studies showing on water holding capacity, increased proliferation and synthesis of human keratinocytes, which is just what I was talking about, in the epidermis. Epidermal hydration is improved. We've mentioned that already. An interesting thing is there are both ER alpha and ER beta receptors in the epidermal keratinocytes. And this was in doubt for a long time, but yes, there are lots of receptors all over the skin in different percentages, such that in your vulva, you have the highest concentration ever of these receptors. Interestingly enough, you have a very high concentration of vitamin D receptors in your vulva as well, which is an interesting finding, to say the least. And why do I mention vitamin D receptors? Because they belong to the same family. Estrogen receptors, vitamin D receptors, and thyroxine receptors all belong to the same family. And vitamin D, like estrogens, is derived from cholesterol to begin with. And transepidermal estrogen hormone replacement therapy has been shown to reduce transepidermal water loss. I mean, really, estrogen is estrogen, but if you deliver it through a gel, you get better results. My first work was on gel to begin with. So what about wound healing? Now, wound healing changes with age. We all know that wounds that heal much less quickly, take longer to heal in older women. So there's been some work by Ashcroft and Ashcroft et al., some other authors recently, both on rats and on human beings, showing that estrogens will reduce estrogen replacement in a woman without estrogens, will reduce the wound size and stimulate matrix deposition much quicker. So healing occurs much quicker, angiogenesis happens much quicker. You might possibly get keloid formation there. In the presence of estrogens, keloid formation is much commoner, but at least the wound will heal quicker. Okay, what about hair loss? Well, hair loss, you get thinning of hair. Obviously, this is a very important change for postmenopausal women. They can get thinning of hair, male pattern hair loss, and you can get this frontal retraction of hair, and it's normally associated with testosterone levels. But the role of treatment with androgens and estrogens for such a condition is still being studied. Can we reverse hair loss with estrogens? Well, some people think yes, some people think no. The main reason why people lose hair is because you get your testosterone being converted to dihydrotestosterone with 5-alpha reductase. So sometimes there's some argument for 5-alpha reductase blockers. It also boils down to your choice of gestogen. We know, for example, that drosperinone is an anti-5-alpha reductase, so we use drosperinone as a gestogen in your HRT, you might have an advantage, theoretical advantage. We know that there's a role for spironolactone as well, but that, of course, is not a gestagen. It's mild diuretic, but it's also an anti-5 alpha reductase. What about vaginal dryness? The vagina is also part of the skin. Please don't confuse your vagina with your vulva. They're very different. But the vulva is also part of your skin. And so you get vaginal dryness, vulval itching very often, okay? Irritation, burning, itching happens in your vulva, but can also extend to your vagina. The two areas are very different because the vagina itself has got a different epithelium to the vulva. The vulva tends to be a thicker epithelium. It's an area of increased blood supply. They've got the highest concentration of estrogen receptors, as we mentioned. So it's no surprise this is one of the target areas that's most heavily affected with aging. You get diminished lubrication, dyspareunia, discomfort with sexual activity, post-coital bleeding. So in addition to your loss of libido because of your menopause, you've also got pain with intercourse. Makes it less attractive, obviously. You get because of tissue changes, you might get reduced arousal and orgasm. Sexual activity becomes much reduced. You get dysuria, mostly because of the base of the bladder derived from the Müllerian tubes itself. Basal bladder derived from the perineum itself, not from the Müllerian tubes, undergoes changes postmenopausal and transitional epithelium changes to squamous cell epithelium. So the base of your bladder becomes very irritable. Very often, symptoms of cystitis, frequency, and urgency are confused with cystitis. People are given unnecessary antibiotics and giving them a much worse cystitis to begin with, or what's even worse, giving them interstitial cystitis, which is really difficult to treat. But anyway, nowadays we've got treatments for that, but you have to realize that a lot of the urinary frequency and urgency coming from the bladder is simply the fact that the lack of estrogens have led to a conversion of transitional epithelium to squamous cell epithelium in the base of the bladder. So what's the treatment of choice for vaginal atrophy and GUS, genital urinary syndrome? Which is the frequency I was talking about, where vaginal estrogen still carry on being the mainstream, mainline treatment, tablets or creams, so we can treat the patient topically or systemically, or both. I think if they've had a hysterectomy, I would recommend both. Vaginally, of course, we can get away with lower doses of estrogens. Nowadays in the UK, you can buy such estrogens over the counter. They are angiogenic, so you will have your blood supply replaced, your collagen is improved, your epithelium is better, and you've got direct relief, which you will not achieve with systemic use alone very often. So that's why I would recommend using both, particularly if you had a hysterectomy. There are other serums, ospemifene, for example. If you take ospemifene, which is the serums, a selective estrogen receptor modulator, it's now registered. You can take an oral pill every day, and you get agonistic effects on the vaginal epithelium, but it's antagonist to breast and endometrium. So you're getting some protection against breast cancer, which you get with any serums, and to be honest, can get with estrogens as well, but we'll just say leave it at that for now, discuss the own terms. But it's agonistic on the vaginal epithelium. I would like to remind you that fluoxetine is the same. You can get agonistic activity on the epithelium as well. You can get agonistic activity on bone, skin, but it's antagonist to breast. And tamoxifen, agonistic activity on the uterus, because you can get endometrial proliferation, but antagonistic to breast. So ospemifene has been shown, but ospemifene is actually registered for vaginal atrophy and GUS. It relieves painful sex symptoms with moderate or severe GSM. Might take as long as 6 months, however, to experience benefits. So you need some patience there. There's no harm in using the two together, the ospemifene and vaginal pessaries. It's contraindicated then, ironically, with breast cancer or high risk of breast cancer. And this is one of the safety safety contraindications that are put in your inserts, because it makes absolutely no sense to say it's contraindicated when it's been shown to be antagonistic to breast. But anyway, that's how it is. And there's lesifoxifene, which is an alternative serum, still in phase 3. I have to wait for it and see what the results are. It seems to be very promising. What is really interesting is the hydroepiandrosterone acetate. Presterone. It's been around for ages. Now it's marketed as Presterone, for example. Because there are other preparations. But the problem with the HA very often is that it's not, it being not so regulated. You tend to find doses that vary within the same batch, for example. There's also inter-batch variation because at the end of the day, it's a health product. However, Presterone is a proper formulated product. The dosage is relatively consistent and taken orally daily, and it's FDA approved and is being very, very successful in preventing and in relieving vaginal atrophy. Finally, there's a laser, which we are getting a lot of experience with these days. There's no doubt that I tend to use an air beam laser, but there's also carbon dioxide lasers. There's no doubt that lasers, especially with the air beam one, will target areas where there's some water and then dissipate. So you can get high energy in 0.1 to 0.3 of a millimeter. So you don't get depth, you don't get burning, you just get stimulation of stem cells. It is stored, which lead to a resetting, if you like, of the biological clock, leading to a thicker epidermis and a thicker dermis and thicker, more vascular dermis. And 3 episodes of laser treatment, 1 month apart, are meant to last for about a year. And there are increasing publications showing this now. The bladder itself, you can improve postmenopausal urinary symptoms using laser in the vagina itself, but there is also intra-bladder laser. There's some improvement in stress incontinence, some use of it in the uterine instability, vaginal itching, atrophy, and lichen sclerosis. Quite a number of studies showing that at least it is very useful, particularly in lichen sclerosis, which is really tractable, and for which there's very little by way of treatment other than mutilating surgery. But at least patients are so relieved to get rid of this terrible itch and pain that they put up with it. But with laser, you can get away with quite a number of cases without having to resort to stage to itching. I've had some very good results with this. Of course, you need biopsies to make sure you're not dealing with something worse than lichen sclerosis. Okay, here are some references which you might want to take a photograph of. I think I'll move on now. DHEA we've mentioned, and Presterone has been FDA approved. We are quite enthusiastic about this because it's very straightforward, no real side effects. On the cascade, on the hormone cascade, DHEA is above testosterone, obviously. Testosterone is derived from DHEA, and so are the other sex steroids. So you might argue, why not give testosterone to vaginal atrophy, as used to be the case, particularly for vaginal sclerosis. But here we've got a very effective oral tablet with over 60-70% success rate, FDA approved, and it's very easy to use. Plus, it gives people a feeling of well-being. Here are the references. Some evidence that Presterone itself reduces UTI associated with GSM in postmenopausal women, because although I did say that cystitis and dysuria are not actually to be confused with UTIs, certainly these women have got still a higher incidence of cystitis. So you do need to check and make sure that they don't have cystitis. But what we need to avoid is the recurrent use of antibiotics, the needless use of antibiotics, because that will give rise to antibiotic-resistant organisms. Plus, it will actually affect the epithelium in the bladder itself. Okay, some more DHEA. These are the studies that shows that the prevalence of UTI was increased threefold with GSM compared to matched controls. And they had an increased frequency of UTIs in the 12 months following diagnosis. But when compared to untreated women, the treated group had significantly lower UTI incidence of UTIs within the first 12 months from the first prescription. So here's another advantage you might get. Now, moving on to other organs, other systems, we go to blood vessels. Now, the carotid artery has got the advantage of being relatively accessible to study. It is thinner women who've had hysterectomies, postmenopausal women, and it's actually one particular study showed that the carotid artery itself is thicker and more elastic in women who've had their ovaries conserved as opposed to women who've had a hysterectomy. And here's another study shows it's associated with large artery stiffening. Now, the carotid artery, the media, it's got the externa media and the intima. The media itself is virtually 100% connective tissue, once again. The intima itself has got some connective tissue in it, but it's prone to being an area where you can get atherosclerosis, for example, and the external is very thin. But using high frequency ultrasound, it's possible to distinguish between the three. Here is one of our studies here, which was published, Maturitas, some years back, and was repeated by other centers, and a cross-sectional data with controls, oral HRT, our favorite implants here again, and you can see that there is a dose-related increase thickening in the carotid artery media. This is the media of women. You can see media here. Doesn't mean that we carry on increasing ad infinitum forever, but you can see a virtually straight line. Here we're using 2 milligrams of 17 beta estradiol. Here we're using 50 milligrams of 17 beta estradiol implants every 6 months. And you can see that you've got this very nice, almost straight line increase in connective tissue. And if you look at the intima, which we said is a factor of a bit of connective tissue and atherosclerotic plaque. So here we don't want the intima to be thick. If it's thick and stiff, it's more likely to throw off thrombi and give a woman strokes. And we found in the same group, with an intima media thickness, which refers to your collagen element, you can see that there is a very neat decline in the non-collagenous element in the intima in women who were on implants. And this must be a good thing. We repeated this work on the femoral artery and found exactly the same results. Okay, muscles, once again, there is a window of opportunity for muscles. Exercise is very, very good. However, every time you exercise, you've got some injury to your muscles. Exercise alone. And so you've got two things. You've got HRT gives you positive effects on muscle repair, enhanced exercise effects, and enhanced connective tissue turnover. Now, if you want to look for sarcopenia papers, they're mostly in sports medicine papers, although they're interested in them increasing in other journals as well. So the hormone therapy itself attenuates, slows down, and exercise-induced lethal muscle damage in postmenopausal women. And postmenopausal women who are not using hormone therapy will get greater muscle damage because they exercise and they get these micro tears in the tissue, and you can actually measure that damage biochemically. But what many of these papers say is that you can exercise as much as you like, you still get compensation for your lack of hormones, for your lack of HRT. So you can see once again, maximum contraction per unit of muscle is better in women who are on HRT as opposed to women who are not on HRT. And the effect of muscles of CZ treatment was not lost. The improvement keeps on being seen several years later. As we see, if you look at the WHI study, you can see that the benefits from HRT, even after 5-7 years, are evident 17 years later, albeit on other conditions. Okay, but WHI paper from 2017 shows that some HRT will keep on, benefits derived from HRT will keep on being seen several years later, but you do need a certain amount of HRT. I mean, most of them would say 5 years to have a carry-on effect that is noticeable 20 years later. The discs are slightly different from a connective tissue viewpoint because the collagen here is mainly type 2 collagen. Now, collagens come in 5 major types, and there are other subtypes. But type 2 is not like bone, which is type 1, and was thought to be unaffected by estrogens. But in fact, once again, there are estrogen receptors here. The nucleus pulposus in the middle tends to be hard. Here it's soft type 2 collagen with molecules which tend to be very hydrophilic. And there are blood vessels here on the side. With lack of estrogens and aging, you get a change from the very rubbery, spongy type 2 to type 1 collagen, to type 3 collagen, which is stiffer. And this annulus pulposus becomes harder, and the blood becomes more avascular, leading to less water content. Now, the discs are very important because they are your shock absorbers for your spine. We know that the vast majority of crash fractures in the vertebrae cannot be attributed to bone density alone. So this 20% of your spine is vertebral discs. The shock absorber status of your discs, if they are changed, you have different compression forces on your vertebrae, which can more easily lead to crash fractures of your vertebrae. So one particular study that we carried out, we're able to show that there were 3 groups of women, and I'll show you here. Big groups of women were seen. In those days, we were still using strontium radiated. But the first thing I'd like to show is that we have the same decline at around the time of the menopause in disc height. And here we're measuring L1, L2, L2, L3, L3, L4. There's 3 discs, and you can see this rapid 30% decline that you see in skin, that we see in bone. So all collagen connective tissue seems to behave in the same way. Lack of estrogens, 30% loss, and then it levels out. So here's one study that was published. We saw that with HRT, the vertebral disc height was unchanged compared to premenopausal women. However, and the HRT groups had a higher value than postmenopausal groups in their vertebral disc heights, and was superior to all other treatments. Strontium is not used anymore, but the most worrying one was the biphosphonate groups, who had very thin vertebral discs indeed. And this is not a coincidence, because we worry that biphosphonates are actually not neutral when it comes to angiogenesis, but they are anti-angiogenetic, possibly anti-angiogenetic. So see the effects that you've got in areas where you've got a rapid blood flow, like for example, the jaw. That's why we can get our dental problems. So just a word of caution, biphosphonates, I'm not saying that they're not good, they're excellent in preventing fractures, but they are not as straightforward as HRT is when studying their physiological effects. Okay, so I need my mouse. Here's my mouse. And also, the interesting thing is that the lowest ones of all were the osteoporotic patients who had sustained a fracture. Here they had very low intervertebral disc thickness, and the discs were very thin, and they were basically lowest of all the groups that we looked at. I did say we looked at premenopausal women, women on HRT, women on bisphosphonates, women on calcium alone, and strontium has since been withdrawn. So I did say how we're measuring them. We're measuring the thickness, the heights on just a bone densitometric image. We were adjusting our calipers so we could measure the intervertebral disc heights. And we can see that with age and with osteoporosis, you get the thinnest heights of all. So menopause is associated with this degeneration of the lumbar spine. The association occurred most in the first 15 years after the menopause. There's 2 authors there, and it can be prevented or reversed with adequate hormone replacement therapy. We don't have enough information on SERMs to be able to comment. Osteoporosis here. Talking about osteoporosis, but basically osteoporosis is a condition where you've got less bone, and with less bone, you're unable to withstand the common stresses of everyday life, and tend to fracture more easily. So if you look at a picture like this, you forget that bone is not just calcium. 2/3 of it is mineral, this is true, but 1/3 is also made up of type 1 collagen with its osteoclasts and osteoblasts. Osteoclasts are like macrophages in connective tissue and skin, and osteoblasts are the bone-forming ones. Now, whatever sort of estrogen you use, be it transdermal or oral, this is work from Steve from Hillard, you can increase your bone mineral density to statistical levels, whereas your placebo group here shows the decline that you get in those early years of menopause. And the yellow one is oral, the blue one is transdermal estrogens. Statistically significant differences. This is work that's been repeated time and time again. We know that HRT is good for your bones. Why and how does this happen? You say that your bone mineral density increases, but your bone mineral density needs to be sitting on a collagen matrix. Well, collagen bones are made of osteoblasts and osteoclasts, as I mentioned, and we can measure the procollagen levels, which is an index of osteoblastic activity, basically, because the procollagen molecules are lopped off. Crosslinks is bone breakdown, collagen breakdown. And here we have our untreated and treated groups, cross-sectional data, and this is a so-called coupling mechanism. So your instinct to say, look, in vitro shows us that estrogens increase osteoblastic activity, and in vitro it shows us that estrogens can decrease osteoclastic activity. So it's very easy to say, osteoblasts go up, osteoclasts come down. This is not true in nature. In nature, you get a coupling mechanism whereby you get a resetting of your coupling mechanism so that your osteoblasts are down as well by 11.3%. But look at your osteoclasts, they've really crashed down to 7.2%. And looking at chain differences in bone density in this particular group, we very neatly got the same result and an increase in bone density that we got through the resetting of this particular coupling mechanism, which left us with an excess of 16.1% bone mass, which is the same as the bone density we got. And these women will be on HRT for at least 2 years. This was a very neat study, published in Maturitas, and showed that what we are dealing with here is a complete readjustment of the coupling mechanism in bone formation. So concluding here, aging causes changes in your skin thickness and your skin collagen. Aging causes inflammation in your skin collagen, your skin thickness, easy tears, easy injuries, easy bruising, and inflammation that's released from this particular physiology has got widespread effects on other systems which are related to menopausal changes and aging changes. Now we know that women get more Alzheimer's than men do, for example, and they're going to be more prone to these aging changes because of the more severe skin loss in the first 10 years after menopause. 50 to 60 years, they're going to predate changes in men by a number of years. We know that skin thickness and skin collagen content can be modified with hormone replacement therapy. So it's just that skin collagen changes actually reflect skin collagen changes elsewhere. So it's a model for wherever you measure collagen, you're going to find the same thing. You're going to find a 30% decline after your menopause. It's all hormone sensitive. Estrogen receptors are very, very widespread. Blood vessels, bone, vertebral disc, we have been able to show the same changes occur in the skin from a conceptual point of view, but also from a quantitative and qualitative point of view. The muscle bulk itself seems to be negatively impacted by menopause as it is with age. It is suspected that HRT blunts this negative impact, and that exercise alone is not enough, so it's worth adding hormone replacement to women who are exercising, who are postmenopausal, to get your best results. And wound healing is improved with HRT. Now, whether we're going to recommend giving HRT for a short period of time in women who are about to have an operation, it's something that needs to be considered. But right now, we have studied women who are HRT versus women who are not on HRT. Hormone treated and premenopausal women have thicker intervertebral discs than untreated postmenopausal women. And alteration in the extracellular matrix and intervertebral disc, the extracellular matrix, appears to be intimately related to the menopausal process, and undoubtedly the loss of disc height predates osteoporotic fractures because fractures do not occur because of lack of bone density alone, but also because of the vertebral disc status and because of the lack of connective tissue status in those bones, or any bones for that matter. And I'll find a slide here. When treating vaginal atrophy, there are several options from non-hormonal, such as, which we did talk about, non-hormonal options, such as moisturizers. A lot of vaginal moisturizers around, which are very, very good. They introduce hydrophilic molecules in there. There are hormonal options, including SERMs, including the HCA. And there are laser options. But such treatment can be used alone, but there's no harm in using them in combination. Treatment should be used individually. Should be individually designed for every woman. We are now concentrating in menopause on individually treating each woman as an individual and getting this sort of treatment combination that suits that particular woman and her situation. And it depends on her clinical history, risks, and response to such treatment. Thank you. This is the end of my lecture.
Very excellent lecture. We have a lot of good questions coming in. I wanted to make a comment briefly about Dr. Greenblatt that you mentioned. Unfortunately, I never had the privilege of meeting him, know of him very well. He's a household name here in Augusta, as I'm sure you know. He passed away in 1987, so I've only had the ability to get to know of him through word of mouth from all of the folks here that did have the privilege. But he had our library is named after here at the Medical College of Georgia, and I know obviously IMS and the Menopause Society recognize him. He was quite a man for sure. So I have a question, and then I'll
when I was young, right, a trainee.
Yes, sir.
I'm not boasting, but it's on my CV. I won the first Bob Greenblatt Prize
Did you?
with him in attendance, yeah, in Orlando, on collagen work, on this work. So
Excellent.
I just have to say it because he did establish a prize for the IMS, which is still going on actually.
Yes,
But
it is.
I did actually meet him through my boss. I was still quite young, but anyway, I was very lucky.
Very good. So I take care of an affluent population of women about an hour south of where I'm at. And a lot of them have concerns about their skin. And I've even had several women tell me that they have used topical estrogen on their face to treat wrinkles. Now, we
Yes.
don't have anything FDA approved for that, no prescription. So that's just off label and anecdotal. They do have beautiful, shiny faces. I've got 80-year-olds that some look like they're 60. I'm just curious if there's options that you're aware of or that you would recommend from a hormone standpoint for treating the face specifically to help with that.
Okay, so the very first important thing to keep in mind is that it must not be alcohol based.
Right.
Okay, so there are alcohol-based estrogens, which are freely available, estrogel, which should not be used on the face or on the vulva, because we learned through bitter experience that they cause a lot of burning sensation. Secondly, you've obviously got women there who are exposed to sunlight, and who might have in their childhood not been so assiduous as they are today in using sunblocks. So there's a bit of a problem there with keratin degeneration because of sunlight, which I have, having lived in Malta, when I was young. So, so my answer is that, and come to that point, that there are several cosmetic companies who are using phytoestrogen creams. I won't mention products because we're not allowed, and they ironically mention our work to justify their use of phytoestrogens. So there are products that are phytoestrogens on the market. I personally see no problem in them using estrogen preparations locally, providing that they are aqueous solutions. And I can imagine they've got lovely skin. But my interest in collagen started because I had, when I was still a trainee, a research fellow, I was meant to do something completely different. But I used to look after an implant menopause clinic in the morning and the gynecology clinic in the afternoon. And there was no doubt that the morning women had much nicer skin, much brighter skin than the guy in the clinic that I was seeing in the afternoon, in a semi-affluent, a mixed affluent, not so affluent. And that's where it clicked, sort of thing. And so whether systemic estrogens are as good, I am not sure, because we were giving systemic estrogens and measuring Thai skin collagen, for example, which is quite far away. And we were using gels, and which were not popular in the UK at the time, and we were using implants and oral. So I would have nothing against them using. The French are into studies on wrinkles because it's not very easy to study wrinkles. So yeah, if you've got a nice safe preparation, low dose, go for it.
Excellent. And then this is a question from earlier on in your talk about estradiol therapy. You were talking about patients who were on it. This person wants to know, did results last once estradiol was stopped? And could you expect that to last for a certain amount of time? Or does the skin quickly change after coming off of estradiol?
Yeah, the skin. As I said, if you take it for 5 years, there seems to be a lasting effect. You delay it, just like you delay osteoporotic fractures. So if you look at the WHI study, I had the name in my head just now, Kamposky et al., the 2017 paper anyway, which showed that osteoporotic fracture deaths were much less 18 years after into the study in women who'd been on HRT for just 5 years. Maximum 7 years, because that's how WHI was. So the effect on osteoporotic fracture was long lasting. And we were still seeing beneficial effects 17 years later, and then there's 20-year update. So yes, yeah, the effect should be long lasting, but it's the hydrophilic element that's the one that disappears quickest, because the hydrophilic element tends to be very finely tuned to estrogen. So I think you will very quickly get dry skin if you come off estrogens completely.
Okay. And then are you aware of any head-to-head comparisons between estradiol versus cosmeceutical products like hyaluronic acid, glycerin, in terms of outcome on skin hydration?
No, I'm not aware of any. I'm not sure if there are any actually.
Yeah.
But we don't know everything. So there might be. All I know is that there are phytoestrogen preparations who claim to have the same results as estrogen. So probably, and they are French products. So probably those ones have had some sort of head-to-head preparation. And the other problem is that we don't have studies with comparing with SERMs either.
Okay. Yeah.
We've got bones with SERMs, but we don't have skin.
Right. So
Yeah.
for patients with past breast cancer, would you recommend prostrate to those patients, or is it contraindicated?
Progesterone isn't contraindicated as far as I know in breast cancer, and testosterone should not be contraindicated either because it's been studied by Greenglass. They've shown testosterone to be protective against breast cancer. I mean, it's an interesting question. Should vaginal estrogens be contraindicated when with breast cancer? That's the other question. Scientifically, probably not. Medically,
Right.
legally, probably yes. Yeah. So that's where we live in. But certainly, these vaginal moisturizers are very, very useful in breast cancer patients, and laser, of course, is very, very useful in breast cancer patients.
Right. And, clinically, this is, we're trying to help outcomes and, make sure that we're treating these symptoms properly so that they can have a good quality of life. And there was a small pilot study that was published, I think, in 2022, 10 breast cancer survivors given prostrate over 6 months.
Yeah,
And it looked like serum estradiol levels did not change much. So remain low,
exactly. Mhm.
and they were okay. Moving on to the next question, what are
Just
your,
a quick point. This idea that
yes,
testosterone is all converted to estradiol is completely wrong. It's wrong because actually it is a problem of a units problem. The testosterone is expressed in units, which are, I think, tenfold less or 100-fold less than estradiol is, picomoles and nanomoles. So if you were to look at the actual amount of testosterone in women, it's consistently higher than their estradiol levels, about 2-3-fold. Whereas, of course, men it's a bit higher. But our estradiol levels are follicular phase. So not all testosterone is converted to estradiol because you find the people who are sort of, why use testosterone? It's pointless. It's going to be converted to estradiol. Well, that's not true. It doesn't happen.
right. And
You
then
still have a result. And the DHA is further up.
any data on DHEA for male skin that you're aware of?
No, I would have to ask Professor Janatsani for that one.
Okay,
He's
all right,
our DHA man,
gotcha.
but I'm not aware of any. But he says his data is anecdotal.
Sure.
So he's very enthusiastic about DHA, and I'm enthusiastic about it as well. But obviously, we've got our estrogens and testosterone, which are
Yeah.
further down the cascade, closer to the site of action, if you like.
So this question is in reference to bone protection with HRT. Now the question is, do you get bone protection if you start HRT at 60? What are your thoughts on that?
Okay, there were studies on that, even from the study group, where they started HRT in women much later on in the 60s, and they did get protection. Actually, the jumps in bone density, actually, interesting enough, were higher. Now, if you looked at our skin data here, you can see that we've got 15 years postmenopausal women who started HRT just 2 years previously, and they soon caught up with the premenopausal levels. My second slide, my first slide was that. We can go back to it and look at it if you like. So this particular study showed that the more you lost, the bigger were your jumps in your early phases of replacement. So if you were just immediately postmenopausal or premenopausal, then all you did was you conserved your bone mineral density. If, however, you had lost your 30%, then you very quickly climbed up to your almost premenopausal base. And it happened, and you probably got bone protection sooner than what you are able to observe from your bone density results, because your bone density results tends to lag behind collagen connective tissue replacement. So there's some evidence that fracture rates were less.
All right, talk a little bit about collagen. Is oral collagen of any use for our patients?
Oral, well, it's debatable. At the end of the day, oral collagen to me is like eating a steak, basically, or jerk, Yeah, so it's converted, isn't it? It's broken down.
Yeah.
But if you're going to ask about injectable collagen for your urethra, then it will probably work, not because itself is going to stay there itself. It's probably going to cause scarring. It's going to cause collagen formation, new collagen formation around it. And there's no harm in using a matrix, to get some bone density. But or I mean, people talk about glucosamine sulfate being used of some use. All I know is it's given to our pets when they've got sort of arthritic pain, so there's no harm in using it.
Yes, my dog was on that as well. So yeah.
There you go. See.
This is an opinion question for you. At what age or how early should premenopausal women consider estrogen treatment? Why?
Yeah, well, it's an important problem. Firstly, peak bone mass is achieved at the age of 30. And now we're looking at oral contraceptive work, for example, which is quite concerning because it might not be, especially low dose pills, might not be adequately substituting the amount of estrogens a young girl has. A young girl has to increase her bone mass, not maintain it. So there might be some evidence that they are not achieving peak bone mass with some of the lower dose oral contraceptive pills, because they're not lipid-like. Now, a woman probably starts her decline in bone mineral density slowly between the age of 30 and 40, but then accelerates in the perimenopausal period. So I think if she is at risk, and now we can tell people who are at risk using a Frex index, you don't even have to do bone density really. If people are at risk and they start having erratic periods, or they might have premature ovarian insufficiency, for example, then yes, of course, they should at least top up what they have, remembering that HRT is not contraceptive. Low dose HRT is not going to switch off your own endogenous estrogens, so you can top up. And the idea is that you mustn't assume that the menopause is a once in a sudden event, because you have your 45 to 50 period where things are happening, so your estrogen levels are fluctuating. But even for some reason that you have changes in estrogen levels, we were able to establish it's not the absolute estrogen that matters, but the fluctuation. And if a fluctuation from high to low, you're still going to be symptomatic. You're going to get your inflammatory reaction like aches and pains in your joints in the morning when you wake up, things like that. So yeah, I think if people are symptomatic, there should be a tailored type of HRT for these women in the perimenopausal period. It's not easy because you have to decide if you're going to go for your fluctuating levels. You might have to use quite a high dose of a natural estrogen, and warn them it's not contraceptive.
Right. All right. And then I see one more question related to melasma. Of course, in pregnant patients, we'll sometimes see melasma with how high their concentrations of hormones get in the bloodstream. Is there an increase in melasma with HRT? And I'll take it a step further. Would you avoid HRT in a patient with existing melasma?
Okay, so for melasma, take it skin pigmentation with estrogens, right? This is just to get our definitions. Well, I'm getting it through sun, So well, let's start off from the basics. Women on the contraceptive pill in a sunny environment get melasma. Yeah, you can always pick them up on the beach. Secondly, right? Secondly, I don't want to be funny here, but it's an issue. It's an issue because it wasn't an issue if you live in the UK, but if you live in a sunny environment, it is an issue if you're on the pill. But anyway, people get by. They don't mind it. They're getting suntanned anyway. The second issue is pregnancy, of course. And it might not always be reversible. That's the other thing. So when you talk about HRT, yes, you can get melasma if you're living in a sunny environment. But it's nothing like the levels of estrogens that you get when you're pregnant. And is it similar to the pill or not? It's debatable. We normally say that 10 micrograms of ethylene estradiol in the pill is equivalent to 1 to 2 milligrams of 17-beta estradiol. So we're using mostly 2 milligrams. If you want to suppress ovulation, when you're doing a frozen cycle in IVF, for example, you've got to use as much as 4 milligrams 3 times a day. So those are the levels where you will get melasma. So the answer is you probably will. Yeah, it's something one has to live with.
Yeah, very good.
Oh,
Well,
you can avoid it with sunblock, by the way.
Yes, yes, wear your sunscreen. So thank you for answering all these questions. If anything went unanswered, or if anyone thinks of additional questions, please send them in. We can try to get them to Dr. Brincat to answer for you. I do have a few slides to share here at the end for IMS, if we could flip to that very briefly. Excellent. So please visit the International Menopause Society website to find out more about all of these educational benefits that we offer and the resources that you see listed here. There's so many opportunities through IMS to understand menopause topics better. So, just like today, we have these webinars, and we really thank you all for being here today. And we'll go to the next slide. A lot of these resources are free, and so we just want to make sure that you all know that there are some exclusive offers for being an International Menopause Society member. If you complete the In-Part Level 1 educational modules, you can get a free 1-year IMS membership, so keep that in mind. IMS membership offers in partnership with local and regional societies as well, who are members of CAMS. And there are monthly live events, extensive library of educational resources that you can access at www.imssociety.org. Next slide. Finally, I want to keep everyone in mind that the 19th IMS World Congress on Menopause is taking place in Melbourne, Australia on October 9th through the 22nd. Which is just around the corner here in a couple of months. Registration is now open. There are many exciting topics lined up in the scientific program and opportunities to network with specialists from around the world. So please visit the Congress website for more information. I want to thank everybody for their time. Professor Brincat, thank you so much for being here and providing us the information that you have today. I definitely feel like I know a lot more than I did an hour ago, and we hope everybody has a blessed day. Thank you.